Hi, and welcome to part 2 of the vertebra. And as we move forward, we've talked about the fact that there are some actual variations with respect to how the vertebra in particular sections of the vertebra are actually different from one another. But then we also have to understand that there is actually variations in the vertebra themselves from individual to individual. So most people actually have 33 vertebrae, but due to developmental errors in utero, people may actually have either 32 or 34 vertebrae. And indeed, estimations on a large scale of course, bones, have said that the number of, or the frequency of abnormal numbers of vertebrae superior to the sacrum, where you should normally have 24, range between 5 and 12%. And the variations in vertebra are affected by race, by gender, and developmental factors, whether those be genetic or environmental. You're more likely to see an increased number of vertebra in males, and a reduced number occurs more frequently in females. And there is some evidence that the variations in vertebra are influenced by race, with some races showing more variation in the number of vertebra than others. So the variations in the number of vertebrae may actually be clinically important. So if you have an increased length of the pre-sacral region of the vertebral column, it actually increases the strain on the inferior part of the lumbar region of the column, owing to the increased leverage that you get there. However, most of those numerical variations, it's not like we see them at birth, but they're actually detected accidentally during diagnostic medical imaging studies for reasons that have nothing to do with back problems, right? So if you go in and you maybe have a rib injury, you go and get an x-ray, then they're like, oh, you've got a few more here than necessary, okay? The variation in vertebra also involved the relationship between the vertebrae in the ribs and the number of vertebrae that fuse to form the sacrum. And the relationship of the presacral vertebra to the ribs and or the sacrum may occur higher or lower than normal. So if it occurs higher, it's called a cranial shift, and if it occurs lower, then it's called a caudal shift. And so as we move forward and we talk about the actual joints of the body, we can actually talk about the symphysis or the secondary cartilaginous joints that are designed for weight bearing and also for strength. Sorry about that sound. So when I'm talking about the joints of the vertebral column, I'm of course talking about the joints of the vertebral bodies, the joints of the vertebral arches. I'm talking about the craniovertebral joints, which are of course the atlantoaxial and the atlanto-occipital joints. We also have the costovertebral joints, which is where the ribs attach to the vertebra, as well as the sacroiliac joints, which attaches the sacrum to the ilium. Now, the joints of the vertebral bodies, in specific, are the symphyses, and they're designed for weight bearing and strength, as I said before. And the articulating surfaces of the adjacent vertebra, for example L4 to L5, are connected by intervertebral discs as well as ligaments. So here we can see the discs in between each of the adjacent vertebrae, and we can see the ligaments, for example, here, that are attaching onto the articular processes. The intervertebral disc provides strong attachments between the vertebral bodies, and they unite them into a continuous semi-rigid column and form the inferior half of the anterior border of the intervertebral foramen. As I've said in the at the start of this lecture, the first part, the discs actually account for 20 to 25% of the height of the vertebral column, and as well as permitting movement between adjacent vertebrae, their resilient deformability allows them to serve as shock absorbers. Each intervertebral disc consists of an annulus fibrosus, which is the outer, more fibrotic part, and then on the inside you get the nuclei pulposus, which is the core of the intervertebral disc. So that annular fibrosus, which is Latin for anus or ring, is a bulging fibrous ring that consists of concentric laminae or layers of fibrocartilage forming the circumference of the intervertebral disc. So just the outside part of it. And the nucleus pulposus, which is Latin for pulpa or fleshy, is the core of the intervertebral disc. And at birth, these pulpy nuclei are about 88% water and are initially more cartilaginous than fibrous. And that semi-fluid nature of the nucleus pulposus actually gives the vertebra the flexibility as well as the resiliency to the vertebral column as a whole. As we know, the thickness of the discs actually increases as the lumbar column descends. You get these relative thicknesses that are specifically in the cervical and the lumbar regions, and the reason that you have what's called the cervical and the lumbar enlargement is because the sheer number of nerves that have to go out of the spinal cord and innervate into the musculature of the arms and the legs needs more space, and that's why those are larger. In contrast, the discs in the thoracic region are much more uniform in nature. Another thing to notice, as you can see in all of these images, is that the discs are thicker on the anterior surface, especially in the cervical and lumbar regions, and their varying shapes produce the secondary curvatures of that vertebral column, right? The curvatures that we see in the lumbar and then in the thoracic spine. So I just want to show you again, you can actually see the annulus fibrosus on the outside, right? And then on the inside there is that nucleus pulposus. Now, vertical forces such as weight bearing or jumping or having a backpack, they deform the intervertebral discs, and that's why they're the shock absorbers. You don't want the bone on bone. The nuclei become broader when compressed, and they get thinner when they're actually tensed or stretched, for example, if you're hanging or suspended. Compression and tension occur simultaneously in the same disc during anterior and lateral flexion, and as well as extension of the vertebral column. And during these movements, as well as during rotation, that turgid nucleus acts as a semi-fluid fulcrum. And because the laminae of the annulus fibrosus on the outside here is thinner and less numerous posteriorly, closer to the spinous process, then you see that the nucleus pulposus, the inside part, is positioned between the center and posterior aspect of the disc. What's an interesting thing is that the nucleus pulposus is actually avascular. It receives its nourishment by diffusion from blood vessels at the periphery of the annulus fibrosus as well as the vertebral body, but in and of itself does not have any nourishment directly to it. So you can see how if you had degenerative disc damage, why if it's avascular it's a lot harder to repair. And so, as I said before, there is no intervertebral disc between C1 and C2 vertebra, and the most inferior functional disc is between L5 and S1 vertebra. If we go down here, I just want to show you what different motions, how they affect the nucleus pulposus and the nucleus annulus. So here, if you're standing upright in good posture naturally, you can see that we have a downward acting force, and what that actually happens when you've got the downward force on the vertebra is that if it's centered, the nucleus pulposus actually bulges out equally in all directions. If you're bending forward, and this is a side view, but if you're bending forward, what happens is you're putting that tension on the anterior part of the intervertebral disc, so you get a bulging of the nucleus pulposus in the posterior direction. Naturally, if we are bending backwards, we get a converse reaction here, so that we're compressing the posterior aspect of the intervertebral disc, which leads to a bulging of the annulus pulposus in the anterior direction. Moving to a single side, for example, so this is looking at it from the anterior view, we see that you get a compression. For example, this is on the right hand side of the intervertebral disc, and it leads to a bulging on the left side. And twisting, for example, so this is why one disc is moving in one direction and the other in the opposite direction, you again get this bulging of the disc in bilateral directions. But naturally what you want is you want to avoid that full compression on the discs as much as possible by avoiding bad posture and twisting and turning too much. So to move on to some much harder stuff, we're going to talk about the ligaments of the intervertebral joints, which of course are there to actually help the vertebra to maintain its position and is also for protection. The first one we should talk about is the anterior longitudinal ligament, and as the name suggests, it's on the front side, on the anterior side of the column, and it's longitudinal, which means it goes in the vertical direction. That's correct, from top to bottom. So the anterior longitudinal ligament is a strong, broad, fibrous band that covers but also connects the anterior lateral aspects of both the vertebral bodies and the intervertebral discs. As you can see here, it's attaching directly onto them. The ligament extends longitudinally from the pelvic surface of the sacrum to the anterior tubercle of vertebra C1, as well as the occipital bone anterior to the foramen magnum. So this is a ligament, although this picture only shows part of it, this is a ligament that attaches up the entire way of the vertebral column. It's thickest on the anterior aspect of the vertebral bodies, and the anterior longitudinal ligament also covers the lateral aspects of the bodies all the way to the intervertebral foramen. Okay? The anterior longitudinal ligament is the only ligament that limits extension because of its anterior position. All of the other ligaments that I'm going to talk about are there to limit flexion. So if this is the anterior longitudinal ligament that of course is you cannot see, you cannot palpate because you've got your internal organs in the way, we can look at the ligaments that are on the posterior side or more posterior to that. The posterior longitudinal ligament, if we look at, this is the anterior longitudinal ligament here, very nice, very thick and broad. Right back here, right in the foramen, is the posterior longitudinal ligament. You can see it, it's very narrow, and in contrast to the anterior longitudinal ligament, it is much weaker. The posterior longitudinal ligament runs within the vertebral canal along the posterior aspect of the vertebral bodies, and it's attached mainly to the intervertebral discs and less so to the actual aspects of the vertebral bodies. And it runs all the way from C2 down to the sacrum, and it actually sometimes bridges the fat and the vessels between the ligaments and the bony surface. The posterior longitudinal ligament, its function is to weakly resist hyperflexion of the vertebral column and to help prevent or to redirect any posterior herniation of the nucleus pulposus because of how we like to place strain on our body. There is also some thought that the posterior longitudinal ligament is well provided with pain sensors, kind of like our nociceptors, that indicate to relevant parts of the cortex and central nervous system that we're having pain. We also have another couple that we should talk about. We have ligaments that adjoin the spinous processes here, and these are typically united by a membranous interspinous ligament and then a strong fibrous supraspinous ligament. So I've noted them in red here for you, so you can see the interspinous ligament, and as the name suggests, they connect between adjoining spinous processes, attaching from the root to the apex of each process. So they span the entire length of adjacent spinous processes. The cord-like band of the supraspinatus ligament, on the other hand, connects the tips of the spinous processes from C7 to the sacrum, and unlike the the thin interspinous ligament, this is a cord-like band, so it's a lot different in nature. So you can see it here, only attaching downwards. Of course, you can't see it because it's not in anything above C7. So, what movements can we actually get on the vertebral column? As you can see in this picture, and also in page 470 of your book, we have a number of movements that we can achieve. We can achieve flexion, moving forward and touching our toes, for example. We can achieve extension, okay? We can achieve lateral flexion and lateral extension, as well as rotation of the head and the neck. So, flexion of the vertebral column is actually greatest in the cervical region. The sagittally oriented joint planes of the lumbar region are conducive to flexion, as well as extension, which is why you can see this curvature of the lumbar spine down here. Extension of the vertebral column is most marked in the lumbar region and is usually more extensive than if you go to flexion. So you can see this curvature of the lumbar is a lot more extensive than down here in flexion. And the lumbar region, very similarly to the cervical region, has intervertebral discs that are large relative to the size of the vertebral bodies. If we're talking about lateral flexion here, we actually see that we get a lot more lateral flexion both in the lumbar region as well as in the cervical region. In contrast, the thoracic region, due to the fact that it has intervertebral discs that are thin relative to the size of the vertebral bodies, give us that relative stability, especially because we have the vertebral column and it's connecting with the sternum and the costal cartilage. So because of the joint planes in the thoracic region, we get rotation here, okay? And this rotation of the upper trunk, for example, in combination with rotation that is provided at the cervical region and also at the atlanto-occipital joint up here, enables torsion of the axial skeleton that allows you to do things such as looking back over your shoulder. That said though, flexion, especially this lateral flexion moving to the side, is very limited in the thoracic region. When we're doing that lateral flexion, where you're going to see it is in the lumbar and in the cervical regions. Okay. So, now that we know what the movements of the vertebral column are, we should talk about the curvatures of the vertebral column. In adults, we have 4 curvatures that occur in the cervical, thoracic, lumbar, and sacral regions. If we have, for example, thoracic and sacral kyphosis, this is where we get a concavity anterior. And if we have cervical and lumbar lordosis, this is where we are concave posteriorly. Okay? When the posterior surface of the trunk is observed, though, what you can see, especially in the lateral view, is that you can actually see the normal curvatures of the spine. 2 degrees in the cervical region, 1 degree in the thoracic, 2 in the lumbar, and 1 in the sacral. And if you've ever been in my lab and seen my x-rays, you'll notice that I do not have that 2 degrees in the cervical region, primarily due to wrestling and doing stupid sports. I should have stuck with lawn bowls. So, the thoracic and sacral kyphoses are primary curvatures that develop during the fetal period in relation to the fetal position, right? So you can see the fetus is very rounded here, yeah? Now, if you compare these curvatures in this figure here, what you note is that the primary curvatures are in the same direction as the main curvatures of the fetal vertebral column. The primary curvatures are retained throughout life as we go upwards as a consequence of differences in height between the anterior and the posterior parts of the vertebra. The cervical and the lumbar lordoses are secondary curvatures that result from extension from this flexed fetal position that we're in up to the upright stance. We start to see these cervical and lumbar lordoses in infancy, that's when you start to see them, and they're maintained primarily by differences in thickness between the anterior and the posterior parts of the intervertebral discs. The cervical lordosis becomes evident when an infant begins to raise or extend the head while they're prone and to hold the head erect while sitting. And the lumbar lordosis becomes apparent when toddlers begin to assume the upright postures associated with standing and walking. The curvatures of the vertebral column provide additional flexibility, shock absorbing, resilience, etc., further augmenting that is provided by the intervertebral discs. So when the load borne by a vertebral column is markedly increased, for example, if you're wearing a heavy backpack, both the intervertebral discs as well as the flexible curvature of the spine is compressed. And when the flexibility provided by the intervertebral discs is passive and then therefore limited primarily to the zygophysial joints and the longitudinal ligaments, then what you have is that the curvatures are dynamically resisted by contraction of the muscle groups that are antagonistic to the movement. And so here we can actually see some of the abnormal curvatures of the vertebral column. And what an interesting image we're seeing here, which shows those, again, the abnormal curvatures of the vertebral column, which I don't think I detected any of you seeing. And so to detect an abnormal curvature of the vertebral column, what you should do is have the individual stand in the anatomical position and then inspect the profile of the vertebral column from the person's side and then from the posterior aspect. And then if you have the person bend over, observe the ability to flex directly forward and whether the back is level once the flex position is assumed. So, there are a number of abnormal curvatures in some people that result perhaps from developmental abnormalities, whereas other curvatures result from pathological processes, for example, during metabolic disease of the bone that occurs in the elderly or in osteoarthritis. If I show you some of these, for example, we can see the natural curvatures of the spine here, both from the lateral view, from the posterior view, and from the posterior bending view. You can see the normal curvatures here, and also the straightness of the spine as it's moving upwards. But if someone has excessive thoracic kyphosis, or which is clinically shortened to kyphosis, what is typically called a hunchback, or a humpback, this is characterized by an abnormal increase in the thoracic curvature, which results in the vertebral columns curving posteriorly. As you can see here, here's the kyphosis of the cervical region that you see. Now, this kyphosis can result from erosion due to osteoporosis of the anterior part of one or more vertebrae, and sometimes it's also called the dowager's hump, which, because it occurs in older women, and dowager, for example, is a Chinese word to where you see the dowager princess or the dowager empress, who was the mother, or in some cases the wife of a deceased emperor. And so because the dowager had a hump, that's how it gets its name. So even though it's called dowager's hump, it's not just limited to men. Anybody with osteoarthritis in the cervical region can end up with this excessive kyphosis or hunching back. Now, excessive lumbar lordosis, which is clinically shortened to lordosis, is known as a hollow back or sway back, and this is actually characterized by an anterior tilting of the pelvis, which you can see right here, and this means that the upper sacrum is flexed or rotated in the anterior-inferior orientation, and it leads to an increased extension of the lumbar vertebra, producing an abnormal increase in the lumbar kyphosis. So this abnormal extension deformity is often associated with weakened trunk musculature, especially the anterior lateral abdominal muscles. And to compensate for alterations in their normal line of gravity, women temporarily develop excessive lumbar lordosis during late pregnancy. But this lordotic curvature may cause lower back pain, but it disappears after childbirth. So that is not what you would see in pregnancy is not the same as actually having excessive lumbar lordosis due to a congenital issue. So, in contrast to these ones that affect the curvature in the anterior-posterior direction of the spine, we also have scoliosis. Scoliosis gets its word from the Greek word crookedness or curved back, and it is actually characterized by an abnormal lateral curvature of the spine, as you can see here in sub-image D, compared to a normal individual. So this scoliosis is accompanied by the lateral curvature as well as the rotation sometimes of the vertebra, and that the spinous processes turn towards the cavity of the abnormal curvature. And when the person bends over, the ribs actually rotate posteriorly on the side of the increased convexity. Now, deformities of the vertebral column, such as a failure of half of the vertebra to develop, are causes of structural scoliosis. And sometimes you get that structural scoliosis combined with excessive thoracic kyphosis, which is called kyphoscoliosis. And this is due to an abnormal anterior-posterior diameter, which produces a severe restriction of the thorax and lung expansion. Now, for scoliosis, approximately 80% of people have this disease. It's idiopathic, and it occurs without any other associated health conditions or identifiable causes. When we think about who's most likely to get scoliosis, it first develops in girls between the ages of 10 and 14, but for boys between the ages of 12 and 15, which to me indicates that it has something to do with puberty, because females typically go through puberty earlier than males. And so, typically speaking, it is more common and also more severe in females. Okay? Now, one of the big things that we've talked about is this idea of osteoporosis, and I'm going to encourage you, as you're now in an age where you can actually do something about it, it's not too late, like myself, to actually make sure or try to minimize your chances of having osteoarthritis, because once you have it, it is not fun times at all. So vertebral body osteoporosis is a common metabolic bone disease that you can actually detect just through a regular X-ray. And osteoporosis, as you all know, results from a net demineralization of the bones caused by a disruption of that normal balance of calcium deposition and reabsorption. As a result, the quality of the bone is reduced, and then you also get a concurrent reduction in the musculature, and so you get muscle atrophy. So although osteoporosis does affect the entire skeleton, the most affected areas are the neck of the femur, which is why people break their hips, the bodies of the vertebrae, the metacarpals of the hand, and also the radius. These bones, the ones that I was talking about, become weakened and brittle and are subject to fracture. So when you take radiographs or x-rays, early and moderate osteoporosis can actually demonstrate demineralization, and that's evident when you look at the radiodensity of the spongy bone of the vertebral bodies, and that leads to a thinning of the cortical bone to appear relatively prominent. And this is what you can see right here in the middle. You can see that the prominence of the compact bone with respect to the actual cancellous or the trabecular bone in the center here. One thing that you might also see is that you get, when you're starting to look at the later stages, you actually get vertebral column collapse or compression fractures. And when you're looking at those compression fractures, where can you start to see them? In this case here, in subset B, we get some striated patterns. For example, you see this in the trabecula. Here in the normal, you don't see it anymore. When you come here, it becomes lost. And the cortical bone wall thin is very prominent. Over here, when we're talking about late osteoporosis, this is in the thoracic region. You can see that there's this actual massive excessive thoracic kyphosis as a result of the collapse of the vertebral bodies that can no longer hold the body upwards, and they become wedge-shaped instead of more flat discs. So So vertebral body osteoporosis occurs in all of the vertebrae, but is most common in the thoracic vertebrae and is especially common in postmenopausal females. Moving on with some other fantastic kind of injuries that I pray that you don't get is a fracture of the dens of the axis. And remember that dens is that ontodontic projection, a tooth that actually is there to help the C1 and the cranium spin on the axis itself. And so the transverse ligaments of the atlas is stronger than the dens of the C2 vertebra, and the fractures of the dens make up about 40% of fractures of the axis. The most common dens fracture actually occurs at its base, so right down here, you can see it, that's where you're more likely to get it, and that's at its junction with the body of the axis. Often these fractures are unstable and do not actually fuse and reunite with the bone on which it came, because the transverse ligament of the atlas becomes intersposed between fragments. And what I mean by that means is that ligament actually gets in there so the bones cannot reunite. So sad. And another problem is that separated dens fragment, when it comes up, no longer has any kind of blood supply, which results in avascular necrosis, or death, so to speak, of that bone fragment. So this type of fracture heals more readily, though, because the fragments retain their blood supply. Other dens fractures result from abnormal ossification patterns that you might see. To make this a smidge bit bigger, as much as I can, you can actually see some of what I'm talking about here, the fractures. So in the coronial scan of a CT, you can see the fracture here. On a medial scan of the CT, which of course is also showing the soft tissue as well as the bones, you can see the fracture here. And these are compared to radiographs, where it's a little harder to see it right in here. Okay? Now, what you're more likely to get, depending, is going to be a extension injury of the cervical vertebrae. So if we look at this, we can see that headbutting or illegal face blocking in football may result in a hyperextension injury of the neck. And this is most likely to injure posterior parts of the vertebra, because what tends to happen is that when you get hit, the head goes backwards and those spinous processes can actually in fact contact with one another and break. Okay? And so such violent hyperextension that we see there can lead to fractures most likely of the cervical vertebrae, and this results in radiating pain to the back of the neck and scapular region, because those same spinous ganglia and spinal cord segments that receive pain impulses from the vertebra are also involved in supplying the neck muscles. Another injury that's quite common is severe hyperextension of the neck, which is called whiplash, that also occurs during rear end motor vehicle collisions, as well as with the football things I was talking about. And this occurs when the head restraint is too low, and these type of hyperextension injuries, the anterior longitudinal ligament, the one that goes actually around the anterior portion all the way from C1 down to the sacrum, actually is stretched and can be torn. Hyperflexion, on the other hand, of the vertebral column may also occur when the head actually rebounds backwards, right? So the hyperextension is when your head goes back and hits the headrest, or if the headrest is not there, just like snaps back. And then what happens is a coup contre coup, the head moves back forward, you get hyperflexion, and where the head snaps forward onto the thorax. And this may lead to facet jumping or locking of the cervical vertebra because of the dislocation of the vertebral arches due to that severe force. The severe hyperextension of the head on the upper neck may also actually produce cervical spondylolisthesis or Henman's fracture. Also, that could rupture the anterior longitudinal ligament as well as the adjacent annulus fibrosus of the C2-C3 intervertebral disc. In some cases, if it's really severe, what happens is that the cranium, as well as C1 and the anterior portion of C2, which is the dens in the body, becomes separated from the rest of the axial skeleton, and the spinal cord is usually severed. So, if you all remember the first Superman, Christopher Reeve, this is exactly what happened to him when he was thrown from his horse. The cranium and C1 was actually severed from the rest of the spinal cord, and he was quite lucky to survive. We may also have a dislocation of the cervical vertebrae that can occur. And how does this occur? Now look at this picture. What you see is that you get these horizontally oriented articular facets, and therefore the cervical vertebrae are actually more tightly interlocked than other vertebrae in the other sections in the thoracic, etc. So these cervical vertebrae are actually stacked up like coins and can be dislocated in neck injuries with less force than is actually required to actually fracture them. Okay? And so, because of the large vertebral canal in the cervical region, a slight dislocation can occur here, and they typically combined with a fracture dislocation that injure the spinal cord. So if that dislocation doesn't result in a facet jumping that you see here in B, so you can see it's actually being slipped and it's actually moving forward on the other, the cervical vertebrae may self-reduce or slip back into place. So in this case here, we're seeing this is just a minor dislocation, and you can see the nucleus pulposus is bulging forward, herniating on the anterior aspect. But sometimes it might actually stay in place, so it comes out a little bit and then comes back in. What is very bad and hurts so much is when you get this fracture dislocation. As you can see in this radiograph here, this vertebra has actually slipped forward anteriorly because of the dislocation of the ligaments here on the spinous process. Boom. Oh, the super pain. I can't imagine it. Another one is a fracture dislocation of the atlas. And remember that the atlas is that C1 vertebra. It's a bony ring with two wedge-shaped lateral masses that are connected by relatively thin anterior and posterior arches, as well as a transverse ligament. Because the taller side of the lateral mass is directed laterally, vertical forces, for example, if you jumped into a pool and you hit your head at the bottom, what it does is it compresses the lateral masses right here between both the occipital condyle and the axis, and it actually drives them apart, and it fractures the anterior arches as well as the posterior arches sometimes. If that force is sufficient, it can actually not just fracture the occipital condyles and the axis, but can also rupture the transverse ligament that links them. And so the resulting Jefferson or burst fracture doesn't necessarily result in spinal cord injury because of the dimensions of this bony ring actually increase, but you will get a spinal cord injury if the transverse ligament has also been ruptured in addition to the fracture of the lateral masses. If we move down to the axis, which of course is C2, this is one of the most common injuries of the cervical vertebrae, and they account for up to 40% of the cervical vertebrae injuries. Usually the fracture occurs in the bony column, which is formed by the axis, and injury of the spinal cord or the brainstem is likely, and this will tend to result in quadriplegia, which is a paralysis of all four limbs, or death. So the fracture of the dens is also common, right? And it's a common access injury, also accounts for about 40 to 50%, and actually results from a horizontal blow to the head, or as a complication of osteopenia, which is a pathological loss of bone mass. And because of osteopenia and the bone mass loss in the dens, it's quite easy for it to actually slip off with exerted force. Okay? So in this picture here, I'm showing you that the pars interarticularis is actually fractured, so it's removing the posterior part from the anterior part, the posterior part of C2 from the anterior part. So we can also fracture here on the moving in between the spinous process in this area. That is quite common. And if you hang yourself, for example, the rope under the chin forces an abrupt hyperextension. This is when here your spinous process is going to touch onto the next vertebra and can actually rupture. Moving downwards to the very, very bottom of our spinal cord, we can talk about injuries to the coccyx. This can occur because of an abrupt fall onto the buttocks, which will cause a painful periosteal bruising or fracture of the coccyx, or a dislocation of the sacrococcygeal joint. Displacement is common, and actually surgical removal of the fractured bone may be required to relieve pain. So if we look at this image here, we can see that just, of course, the C01, the first coccygeal vertebra, is fine because at this stage it's actually fused to the sacrum, but the lower ones here have been fractured off. And you can see this radiographically where the coccygeal here is being removed, has actually come off. So if you have, for example, a particularly difficult childbirth, it might actually injure the coccyx of the mother, and it can actually be extremely painful. Some people might get coccygeodynia, which follows coccygeal trauma, and it's very, very painful. Sometimes a doctor will actually come up through the rectum and actually palpate and move the coccyx, the fractured coccyx part, back into place to relieve that pain. Last one I want to talk about for this is a herniation of the nucleus pulposus, and this is one type of the hernias that you may be familiar with. So for example, if you have violent hyperextension of the vertebral column, you may actually rupture the intervertebral disc and fracture the adjacent vertebral bodies. Okay? And so the intervertebral discs in young people are very strong, and they're actually so strong that the vertebra will fracture during a fall before the discs will rupture. And of course, when you're young, the water contents of the nuclei pulposi are very high, it's about 90%, and it gives them, they're very full, and they're very good at absorbing shock. But when you have a violent hyperflexion of the vertebral column, it can actually rupture the intervertebral disc and fracture the adjacent vertebral bodies, but it has to be a very violent, very sudden kind of movement. In contrast, the flexion of the vertebral column produces a compression anteriorly and also stretches and provides tension on the posterior aspect of the intervertebral disc, and it causes the nucleus pulposus to move posterior towards the thinner part of the annulus fibrosus. And so if that happens, if the annular fibrosis has actually degenerated, the annulus fibrosus, which is of course the outer ring of the intervertebral disc, then the nucleus pulposus can actually herniate into the vertebral canal, okay, and compress the spinal cord or the nerve roots of the chorda equina. And so this is what people commonly refer to as a slipped disc. It's not true. Your disc doesn't slip. It actually just bulges out. So we can see this herniation of the annulus fibrosus where we've got that compression leading to the compression of the spinal cord as it's moving down here. You can also see this in this picture from the transverse view showing it moving in. Also in this transverse MRI we see it just bulging outwards. Okay. So herniations of the nucleus pulposus usually extend posterior laterally, where the annulus fibrosus is relatively thin and it doesn't receive support from either the posterior or the anterior longitudinal ligaments. The posterior lateral herniated intervertebral disc is more likely to be symptomatic and painful because of the proximity to the spinal nerve roots. And so you often get localized back pain of a herniated disc, and it's usually acute in nature, resulting from pressure on the longitudinal ligaments based on the periphery of the annulus fibrosus, and also from local inflammation caused by a chemical irritation by substances that exude from the ruptured nucleus pulposus. If we start to think about where we get those herniations, approximately 95% of the lumbar disc, where you're more likely to get them, occur at the L4, L5, and the L5S1 levels. Now, the marked decrease in the radiographic intervertebral space, what's called the disc height, which you can see here, that may occur as a result of acute herniation of the nucleus pulposus, may also result in a narrowing of the intervertebral foramina, and this perhaps exacerbates compression on the spinal nerve roots, especially if hypertrophy of the surrounding bone has occurred. What we tend to see is that you get these herniations as you get older, primarily due to the factor that your intervertebral discs become more dehydrated and fibrous or even granular with aging, and so it's likely that the nerve roots are being compressed by increased ossification of the intervertebral foramen as they exit. And so that's what I wanted to leave you with today. I hope you learned something and kind of stimulated to continue in learning this taught material. If you have any questions, let me know and I'll be more than happy to help. Ciao for now.